Good afternoon and welcome to Science Gallery at Trinity College Dublin. My name is Aisling Murray. I'm the head of programming here at Science Gallery. A few pieces of housekeeping up top. And we kindly ask that you take note of the exits, which are the doors to the left of the stage and the back of the room through which you came in. In case of an emergency, please follow the instructions of staff and exit the building safely. We also ask that you switch your phones to silent. The event today will be live streamed, but you can submit your questions to the panel via Twitter, and there will be a Q&A at the end as well. We also love to receive audience feedback, so we'll be sending out an evaluation after the event, and if you have a few minutes, we'd love if you could complete it. In 2 weeks, Science Gallery Dublin will have been open for 12 years. And 8 years ago, Science Gallery International was formed from Science Gallery Dublin, with the goal of opening 8 Science Galleries internationally by 2020. This month, we achieved this with the announcement of Science Gallery in Atlanta with the University of Emory. There are now Science Galleries in London, Venice, Rotterdam, Bangalore, Melbourne, Detroit, and Atlanta. And that all started here in Dublin, in Trinity College. Public engagement and discourse is at the heart of what we do in Science Gallery Dublin. We are not the subject experts, other than facilitating discussion, but we have the luck and privilege to have access to expertise, particularly based here in Trinity College. It's been a few years since we've had a rapid response event. We felt that this was important for us to do this briefing today. The World Health Organization are currently meeting in Geneva on whether to declare this a public health emergency. And hopefully during or by the end of this event, we'll have word on the outcome of that meeting. I'm delighted to hand you over to our esteemed panel, moderated by the award-winning science, health and investigative journalist, Maria Delaney. Thank you.
Thank you, Aisling. So welcome to this briefing on the novel coronavirus. Over the next hour, we hope to answer a range of questions, such as who's at most risk of contacting the new virus, how it's spread, and if there will be a vaccine introduced to tackle the new coronavirus. You can also join the conversation on Twitter, as Aisling said, and our hashtag is SGCoronavirus. And also welcome to those watching on Facebook live stream. So we have a great panel of experts here today. I'll just start here with Dr. Cillian De Gascun, has been director of the National Virus Reference Lab since 2013 and is a consultant virologist and Trinity graduate. So he's a fellow of the Royal College of Physicians of Ireland and the Royal College of Pathologists in the UK. So his main research interests are the molecular epidemiology of viruses, antiviral resistance, and vaccine-preventable infections. So he should have some insights on that. Unfortunately, he has to leave at 1:45, so if Cillian just runs off stage, that's we know in advance it's not because of you. So beside him is Dr. David McGrath. He's been a medical director of Trinity College Health Service since 2006. That's back when I was a college student here as well, and is a member of the college's working group on the management of this potential new threat. He was also a member of the working group on avian flu, H5N1, SARS, and Ebola. So he's well used to these threats and will have some advice for us as well. Beside him is Professor Nigel Stevenson, an assistant professor in immunology here in Trinity. His research analyses how viruses target our immune system, so I'll be asking him some questions about that as well. He's discovered new mechanisms by which HIV blocks innate immunity, helping to explain why HIV remains virtually impossible to cure. And his research team investigates the effect of respiratory viruses, including other coronaviruses such as SARS and MERS, and we'll be going into more detail about them as well. And beside me here is Professor Karina Butler, and is a UCD clinical professor of paediatrics and consultant paediatrician and infectious disease specialist at Children's Health Ireland at Crumlin and Temple Street. And she is currently president of the Infectious Disease Society of Ireland and chair of the National Immunisation Advisory Committee of the Royal College of Physicians. So lots of expertise here today, and we'll be answering your questions at the end of a discussion. So we'll give you around 10 minutes at the end if you have any questions. So so first of all, I suppose we want to know, Cillian, if you could say what exactly is a coronavirus and where did it initially stem from?
So coronaviruses, I suppose, comprise sort of a large family of viruses that infect animals, birds, and humans. So we have this new virus is the seventh human coronavirus of the other six that we know about. There are 4 seasonal coronaviruses that don't cause severe disease. They typically cause the common cold. They're sort of catchily sort of named HKU1, NL63, OC43, and 229E. So it rolls off the tongue. And to be honest, from a virology perspective, we weren't hugely interested in coronaviruses for a long time. So we had no antiviral therapy, we had no vaccine. And I suppose the interest was peaked in 2003 when SARS appeared. Well, it appeared in late 2002. In 2003, sort of went global, infected 8,000 people with a case fatality rate of about 10%. And a case fatality rate of 10% mightn't sound terribly dramatic if you don't sort of work in the area of infection. But just to give you some context, the case fatality rate for seasonal influenza is about 0.1%. So 10% is massive. And SARS, fortunately, was readily, once we got up and running, SARS was readily controlled because people were only infectious after they developed symptoms. So quarantine and isolation worked quite well for SARS. And that went away, and that virus now no longer circulates in humans and, to all intents and purposes, is extinct. And we thought it was gone, and then in 2012, it happened again in the Middle East with Middle East Respiratory Syndrome coronavirus, or MERS-CoV, and that has infected about 2,500 people to date with a case fatality rate of about 35%, which is, again, even more frightening. So there's been a lot of interest in coronaviruses over the last sort of decade, 2 decades for that very reason. So both of those viruses appear to have crossed the species barrier recently, sort of just before the outbreaks occurred, and originated ultimately in bats. So what we're assuming with this novel coronavirus, with China has done they've received some criticism, but they've done a huge amount of good work in the first couple of months of this outbreak. All of the virus has already been sequenced. We've already got a diagnostic test available. They're doing a huge amount of screening, and all of the viruses that have been sequenced already are readily available and have been made public to other investigators and diagnosticians. So looking at the virus sequences and comparing those to known bat viruses and also to each other, it appears that this virus has crossed the species barrier probably in late November of last year or December. So the fact that it has spread so widely in the first couple of months is slightly concerning, to say the least. But yeah, so coronaviruses are fascinating. They're one of the largest RNA viruses. They do mutate at a fairly consistent rate. They're also capable of reassorting with each other and recombining, which obviously generates new pathogens. And the reason that bats are such a reservoir for viruses is that they're essentially long-lived mammals. They've been around for about 50 million years, and I think we walked out of Africa about 200,000 or 300,000 years ago. So most of the viruses that can infect bats will use a cellular receptor, and Nigel will know more about this than I will. We'll use a cellular receptor with which we will have an analog. So that's why they seem to be able to cross the species barrier. So most of our human viruses probably originated in bats at some time.
And Karina, maybe you can explain, so Cillian just said that they originated in bats, but how does it go from bats to humans and then human to human?
Well, I think that's a good question. What we see with most of these new emerging viruses or infection is that there is that episode in time where there's a lot of animals and humans together, or animals, sometimes there's an intervening species. So it might start off in bats, and then something happens that changes, and there's a mixture of secretions or the air, and it gets into another animal. For example, with SARS, it was the civet, and they may have closer contact with humans, like in some other areas, different animals are in the big food markets and that. And if there are a lot of animals around, if they happen to be sick animals, if you're carving them up, if secretions are aerosolized, then humans may breathe them in. And then there may be a reassortment, they get together, and suddenly the virus has adapted and is suitable for infecting humans. How we pass it from one to another, most of these respiratory viruses, like our coughs and colds and flus, is in our respiratory secretions. We cough, we sneeze, those droplets get out there. They have a distance of really just a couple of meters, and if you happen to inhale them at that time, you may get it. What we don't know about this particular virus yet as to whether it can actually become what we call airborne. So rather than just being a droplet that goes so far and then will fall to the ground, can it float on the air and move through air currents which, for example, chickenpox can do, the chickenpox virus can do for a while, so that you get much wider spread. So we don't know how infectious this particular virus is going to be. We do know that there has been person-to-person transmission, but most of those events that have been described so far have been in sort of close household contact or in the healthcare environment where, for example, people are doing things close up to people so that they might get those droplets. So we don't know yet what the potential for spread is. For example, if you've got something like a measles virus that's very infectious, you can get, for every person who's infected, you can get about 18 other people infected because you have a high burden of virus in those upper respiratory tract secretions that get out there. Chickenpox, similarly, everyone who has children in daycare knows how infectious that can be because it can linger in the air for a while, even after someone is gone. But for this particular virus, at the moment, there are not too many upper respiratory tract symptoms described. It's mainly down in the lungs, so maybe it won't be as infectious, but we don't know that yet.
I suppose just in terms of infectivity, Nigel, you've done a lot of work on MERS and SARS, you work on it in your lab. Maybe you can just compare the start of MERS to the start of SARS versus coronavirus, because I know today there's even been more cases of coronavirus and more deaths. So is it similar, is it different?
Yeah, so the reality is we believe this is much more infectious. There have been, I think, are there over 7,000 cases?
7,700 was the
and
update.
Yesterday the WHO published that they thought there was nearly 10,000 suspected cases as well. One of the main issues with this one is that there are 20% of those people have severe clinical symptoms, and currently it's all kind of panning out as we go along. But currently, we think the death rate is only 2 to 4%. When I say only, that it's tragic, but compared to MERS, which was nearly 40%. However, MERS has only infected, and I say again, only 2,500 people, and that is since 2012 to now, whereby this one, within 6 weeks, a month to 6 weeks, has infected 7,000. So that's an indication that it's highly infectious.
And in terms of the death rate, is it too early to tell what the death rate could be? Like, people are saying 2%, but perhaps there are people infected that might...
Yeah, we have to try and work out what the situation is at the minute, but it's very early days. They believe the infection rate or spread rate is 2.5 people per person. That's what the WHO have said at this point. So for every person, they pass it on to 2.5 people, if you can have a half person. But I suspect that will go up because we know that it's increasing.
I suppose just in terms of viruses, we know like the flu, like what would the death rate be for that?
That's a good question, probably for the clinicians.
0.1%.
0.1%. Okay, so you can see the difference in magnitude then there straight away.
The only thing is there's a caveat. Whenever you're at the early phase in description of a disease like this, what happens is you get to know of the most severe cases, and you don't get to know of a lot that are out there that might be very mild infections. So you get a skewed representation of what the death rate or the severity is, because they're the ones that you're picking up first. So it's really only much later on that you'll get a good picture of what the actual death rate is.
And David, you're a GP, so what signs and symptoms should we look out for this virus?
Yeah, I suppose so. GPs are usually the first point of contact for people with any medical concerns, and with the amount of media attention on this virus, most GPs are getting quite a lot of queries about it. In our particular situation, I run the health centre at Trinity here, so we have a mobile student population. We've got Irish students studying in China, we've got Chinese students who are here and maybe at home for Chinese New Year. So we have a lot of questions from students, from staff, as to what to look out for. In general, as Karina has said, the symptoms are those of a respiratory virus. And really we have had great assistance from the HPSC, the Health Protection Surveillance Centre, and the Department of Public Health in terms of developing algorithms that we can use when people contact us or come and see us. So we have very specific management tools that we can apply to either people on the telephone or people who come to the surgery. Obviously, it's better if patients don't come to the surgery, because as you all know, with your own GPs, they're busy waiting rooms, so you don't really, it's far from ideal if somebody pitches into a GP waiting room. So the recommendation is that a person telephones ahead if they have a concern around coronavirus, and then we apply an algorithm, a series of questions, and decide whether or not they are at risk, whether they need to be seen, whether they should be seen in a GP setting or whether they should be seen in the hospital setting. And that algorithm has questions such as, have they come from Wuhan or an infected area, Wuhan province, Hubei province, or an infected area in the last 14 days? And that puts you to one side of the algorithm, yes or no. If you haven't at the moment and you don't have a fever or other symptoms, you're not considered to be at risk. If you have been in Wuhan or in an infected area and you don't have a fever and you don't have respiratory symptoms, you're not considered to be at risk. If, however, you have been in Wuhan and you have a fever greater than 38 degrees and you have certain of the physical respiratory symptoms that Karina has spoken about, particularly the lower respiratory symptoms, well then we need to treat that person as a possible case. Obviously, there are risks associated with assessing patients for GPs and for other healthcare professionals, for ambulance personnel. So, when we have a case where we need to assess a case, we have to use all the relevant personal protection equipment, gowning, masks, goggles, that type of thing. So we've done a number of assessments, and I'd say a lot of GPs in areas of the city and the country where there are highly mobile populations, we probably have done some assessments. But as of yet, there has been no case of coronavirus here or in the UK reported.
Right. And Nigel, I heard that it's silently contagious. What does that mean, and why would our immune system not immediately respond to viruses like this?
Silently contagious,
silently.
Yeah. I suspect that is something that's still up in the air as well. I think Karina would agree. We don't... Generally, people will be infected if through airdrops. That's what the accepted infection route is. The WHO have commented on this, that some people have been asymptomatic and have potentially passed on the virus. That may be through something like rubbing your nose and touching surface, and then somebody else touching that, because viruses... one of the crucial things about viruses is they have to live inside your cells. But they can live for a certain amount of time on a surface until somebody touches them and then take them into your mucosa, your eye or your mouth or your nose. And these viruses love to infect the epithelium, which is the cells that line our respiratory tract. And that is why the infection actually travels through a sneeze or in the air, and you breathe that in, or you touch something and you rub your eye. They say those masks, which you have one there actually, they're good in relation to, they don't know if they're really great in protecting you to inhale, but they're the best what we have. But also wearing them makes people think more about touching their face. They have been shown to restrict people from actually touching. You asked about why some viruses don't
So
clear.
why would the immune system not respond to the virus straight away?
Yeah, so that's actually what my lab are working on, and so we investigate how different viruses actually target the immune response. And so if you get infected with any virus, you start producing a molecule called interferon. And interferon is one of the few things in immunology that makes sense. It interferes with viral replication. So interferon acts on our cells inside our body and then induces or upregulates hundreds of antiviral genes. And these all have different functions to target the virus from replicating, from getting into cells, and lots of processes. But what we've discovered is that HIV, hepatitis C, and respiratory syncytial virus all target the interferon pathway. So these molecules all have pathways within our cells that upregulate these antiviral genes. And we've discovered that there's 3 viruses that use a similar conserved mechanism to target this interferon response. And so if the viruses, we call this immune evasion, viruses try to evade our immune system so that they can actually replicate in our bodies and keep going. And so we've been collaborating with Hong Kong University, with labs and clinicians in Saudi Arabia with MERS. Hong Kong University lab worked on SARS and MERS, and also a lab in the University of Maryland in the USA. And we have discovered, and Yamei is a PhD student who just started in my lab on a Chinese scholarship actually, to investigate how MERS and SARS target the interferon pathway.
And I presume that prevents or makes it worse, maybe the symptoms, or prevents treatment, or that kind of thing.
Exactly. So we're discovering that. We're discovering that the MERS and SARS proteins actually inhibit the antiviral genes from being induced, and therefore the virus is able to keep replicating. And
could something similar happen, with the new virus?
Yeah, so Yamei, one of the great things about this discovery is that the Chinese made available and published the sequence of the new virus. So all these viruses are made up of a genome, and coronaviruses are an RNA genome, which Cillian mentioned. And what Yamei did was search that for the particular regions that we know are active in MERS and SARS.
Okay.
And she's identified them in novel coronavirus. So we're hoping now to work with our collaborators on investigating how this novel coronavirus targets the interferon antiviral response.
Perfect. So you're building on work from SARS and MERS.
Yeah, learning from it, exactly.
And Cillian, I suppose we've talked about that, and maybe you can talk about the risk. So, how can we stop the spread of this virus?
Well, I think it comes down to whether the mode of transmission, and if it is a respiratory transmission, sort of through coughing and sneezing, then it's, I suppose, good hand hygiene, good infection control. So, rather than coughing into your hand or sneezing into your hand and touching door handles and stuff to try and sort of cough or sneeze into the crook of your elbow, or if you have a napkin or a tissue or something like that. It's like the good news, I suppose, in some respects from the exported cases is that there hasn't been sustained human-to-human transmission in those countries. So that suggests that with good infection prevention and control, cases can be managed, healthcare workers don't get infected, and family members don't get infected. So I suppose that is a positive thing to take on board. And I suppose the other thing to remember is that it's not really, and Nigel touched on this, it's not really in the virus's interest to kill us because they need a host in which to replicate. But the problem is because they're new to us and we're a new host to them, in the early stages it's not unusual to see sort of quite a significant sort of fatality rate because the virus has to evolve. In essence, it wants to evolve over time. So if you think about something like cold sores or something like that, herpes has evolved beautifully to sort of to live with us. Occasionally it causes very severe illness, but the majority of time it doesn't. It causes a cold sore, it sort of then it remains latent, stays with us for life, and reactivates sort of intermittently when you might be stressed or run down or have an intercurrent illness, and then it sheds and transmits to other hosts, and that's how and it remains latent in them for life. So herpes viruses have been a real success from an evolutionary perspective. So viruses really don't set out to kill us because it's not in their best interest. But obviously over time we see how viruses sort of co-evolve, and typically sort of disease severity and transmissibility don't always go together. So if a virus sort of wants to become more transmissible, I use the word want, it's sort of an anthropomorphism, which is not ideal because there's no grand intelligence behind this, but if the virus becomes more transmissible, oftentimes then it has to compromise on disease severity. So if you look at something like Ebola, the reason Ebola hasn't sort of established itself in humans typically is because it kills us all very quickly. It's not used to us, you know what I mean? We're not the natural reservoir host. So as I said, we want to sort of see over time what happens with this virus. If it could well establish itself and become sort of one of our, if we look back to say 2009 with the novel pandemic sort of influenza virus that appeared in 2009, that is now our seasonal influenza virus. It was new at the time. Thankfully it wasn't terribly severe, but that just sort of became our seasonal virus. It replaced the H1N1 virus we had before that. So
I suppose there are some instances of coronaviruses just being like a common cold. So,
yeah, absolutely. Is that there are sort of 6, there are now 7 sort of human coronaviruses. 4 of them are very mild and only rarely cause severe disease, but unfortunately the other 3 are quite severe at this point anyway.
And I suppose there have been fatalities. So, Karina, like, who would be most at risk? Who are the vulnerable groups?
Well, again, our data, it's really all emerging at the moment. But interestingly, children and adolescents have been relatively spared any severe illness, and it's concentrated in the older age group. Now, it has affected people who have no underlying diseases as well as people who have, but certainly those with comorbidities and older people have been more at risk for severe disease. So that's really as much as we know at the moment. You always worry about people who have problems with their immune system for whatever reason, because they may be more susceptible. But at the moment, it's the older age groups, middle age to older age groups, and those who have other underlying conditions that are more at risk of severe disease.
And we've had some questions actually sent in to us by Cystic Fibrosis Ireland, and they're kind of worried about some of their members who either have cystic fibrosis or maybe are immune suppressed because they've had a transplant, and some of them are abroad, so they're worried about flying. So I was just wondering what precautions, maybe Karina or David, that they should take.
Well, I think it's the same precautions as Cillian was saying. I mean, basically, we want to protect ourselves from respiratory viruses, this one and all the others. So good hygiene, good hand washing. If someone does have a cold within a family group where there's someone who's vulnerable, being careful about that. If you were to take the flu, where we have a vaccine, family members should get the flu vaccine as well as the index patient as well, so as to protect them. So it's about being careful in those settings.
And I suppose just for flying, like, people were wondering, like, this is a respirator, like, should they wear something like this, or should they wear a mask, or what kind of...
Well, you do see a lot of people going through airports wearing masks, but I don't know that there's any really good evidence base to say that they are helpful. If someone has a cough and a cold and they are sneezing and coughing and have lots of droplets, if they have even the surgical mask, that helps them prevent spread it. And again, it reminds you not to put your hand to your face and nose, which we do all the time without realizing it. But how effective, when you see most people wearing those masks on the street, they're not fitted properly, because if you were really going to wear these masks to protect yourself from inhaling viruses or things, they need to be fitted tightly around your nose so that if you breathe in and out, basically air isn't getting in or escaping, it's only coming through that respirator piece. So most of the time, I don't think they've been worn very effectively, and I don't know that we have a lot of evidence base to say that the casual wearing of them is helpful. They are, of course, important in certain situations, and in terms of within hospitals and when you're doing procedures, yes, they're a very important part of our protective clothing.
Perfect. So it's more, it might help spreading, or if you actually have the
If
virus.
you have something, having it on will help stop it going.
Yeah, that's very common in Asia,
Yeah,
isn't it?
yeah.
The wearing of mask when you're sick.
Yeah.
So, yeah, perfect. And Cillian, maybe you can talk about the WHO Emergency Committee. So Aisling mentioned at the start that they're meeting right now. Like, if there will be a public health emergency, do you think there should be an emergency, and what difference would it make if there was?
I suppose I should give a massive disclaimer that I've never been involved in the WHO process, so I don't know exactly. I know what their criteria are. They're based on what has happened to date. The criteria for a public health emergency of international concern have probably been met in the sense that it's a severe outbreak, it was sudden and unexpected, and there is sort of a potential for a global spread. I think the WHO sometimes gets a lot of bad press. They have to really sort of process a huge amount of information and issue guidance. I think they came under a lot of criticism in 2009 at the time of the pandemic, which is probably a little bit unjustified, because as a health organisation they really have to err on the side of caution. I think one of the criticisms levelled at that time was that when the pandemic didn't turn out to be as severe as expected, there didn't seem to be a mechanism in place for them to de-escalate. from the pandemic setting, and that was, as I said, they got a lot of criticism because of that. So I think that it's possible that last week when they met, they were cognizant of the criticism that had come in the past, so they were trying to be cautious, and also they were basing it on the fact that the virus at this stage was, or when they met last week, was fairly much confined to China. Although cases had been exported, sustained human-to-human transmission had not established itself in any other country. And really that's what the FEC is designed to sort of challenge, or designed to sort of address. If they feel that there's a single country that is containing an outbreak and can manage by itself, then they probably won't declare a public health emergency of international concern. If there's a sense that China may be, and it's not a sense of criticising China, because they have put in a huge amount of work and put in incredible sort of health prevention and protective measures to try and contain this thing. But if there's a sense that they are no longer capable of managing this by themselves, then that's where the FEC comes in. So this becomes sort of, we need the global community to get on board and to try and manage this and control this. And I think
are we not already doing that though? Like, what difference would actually declaring it an emergency be compared to what it is now?
Well, I suppose there's still no, from a WHO perspective at least, there are still no travel and trade restrictions on China.
Yeah.
Obviously some airports, as you said, have sort of, some airlines have stopped flying, some countries have introduced sort of airport screening. We don't really know the efficacy of that, because, sort of as Karina alluded to earlier, not all patients are going to be, say, febrile when they go to the airport, and if they're asymptomatic they may still transmit. So with SARS we got a bit lucky in some respects, because most patients were febrile and most patients were only infectious from the time of the onset of symptoms. So it was easier to control than this novel coronavirus. But I think if you saw that, yes, if they decide to declare, and they also came in for criticism last week when they decided not to declare a FEC, and we know from their statement that the committee is divided. So the fact that they're reconvening today, I would probably be surprised if they don't declare it. And I said, I think you'll see more global measures and global sort of travel restrictions and that type of thing in airport screening.
Right, and David, Cillian mentioned pandemic there. What's a pandemic and what's an outbreak? What's an epidemic? These words are kind of buzzed around, but what do they mean?
Well, they're technical definitions for the virologists, I think, not for the GP. I mean, I suppose we've had experience as, you know, a university is like I look at it like a small town with 25,000 people, where most of the people are under the age of 25. And in these previous outbreaks, particularly the H5N1 outbreak, the avian flu outbreak, they did have a really significant impact on services and demand, and actually, you know, people's ability to come to college. With regard to this particular outbreak that we haven't had yet, the concern really is in terms of the severity of the potential severity if we do get cases. I mean, I'm very reassured by the fact that it's only 4 or 5 days since the direct flights from Wuhan to the UK have been stopped. And prior to that, there was probably a 3 or 4 week period, maybe even a little bit longer, where thousands of people have flown from Wuhan to the UK, and there are no cases that we know of, or there are no laboratory verified cases in the UK, despite direct flights and thousands of people flying from Wuhan. So to me, that is a positive indicator. Obviously, everything will change for us if we do get a case, and it's really about us being prepared for the fallout if we do get a case. And obviously, I look at us, we're like a small town, 25,000 people. We have a responsibility to our students and our staff, and at the same time we're trying to run an organisation, a university, but the priority is obviously the health and welfare of our staff and students who are here and also who are abroad, and we've had to make some decisions and recommendations as to whether we should ask people to come home if they're abroad, and we are doing that for the small number of students that we have in China, purely because the situation there seems to be evolving and it's outside of our control, and that we feel that our students there, they can complete the rest of the semester here, and at least they're guaranteed to be in a safe place. And we've made that decision based on the Department of Foreign Affairs travel advice, which changed yesterday, which now says that travel to those areas is not recommended. as opposed to we don't advise non-essential travel. They've actually recommended that people do not travel. So we're just following really directly the guidelines that are coming out from Foreign Affairs and from the HPSC. And I think if we all do that as the health body, GPs, consultants, if we all stick to the same plan, it'll be very clear as to how we manage any outbreaks. If different groups go on different solo runs, you hear a lot about people self-containing, withdrawing for 2 weeks after they come back from China, or other areas that are, where a very small number of people have very small number of cases have been identified. So the HPSC has come up with very useful information for returning students to third level institutions and said that, quarantining yourself for 2 weeks is not indicated unless you have follow very specifically along the algorithms. And that's been very helpful because people feel a personal responsibility when they come back from these areas. They're worried, about infecting other people, even though they don't have the infection themselves, but also the perception of, this person has come from a particular area. So I think if we follow the algorithms, they seem to be particularly helpful in terms of managing the public concern around that. And if things change, obviously those algorithms will change.
I suppose just in terms of preparedness, one of the things that people think about when they think of viruses is a vaccine. So Nigel and Karina, maybe you could say, is it possible to develop, or Nigel, is it possible to develop a vaccine, and how long would it take? Because these, say for influenza, they nearly start the process the year before. So how long would it take to develop a vaccine?
Yeah, so there is a research network working on this, and there are at least 3 groups trying to develop a vaccine against this. And there are phase 1 and phase 2 clinical trials for vaccines on mares going on at the minute as well, and the WHO is helping with that network. Vaccines take a long time to produce. Because
you're saying there's clinical trials for mares, and mares has been out for a long time.
Yeah. So, and also vaccines happen if there's a will and a finance behind it. And so lots of viruses that have evolved in the past maybe occurred in countries that there wasn't an economic sense for a pharmaceutical company to really push. However, this situation, it's an outbreak in China, one of the richest countries in the world, and one of the countries that could have a huge research background that could really work on this. And I know that they are, within China, developing a vaccine. The problem is, a vaccine has to be safe and effective. So the effective bit will be the initial testing and the working out, does it work? But then we can't just give people vaccines without checking. In animals is normally the first route, the toxicology and the effectiveness, but then in patients as well. However, when Ebola broke out, there was a kind of route to try and develop a vaccine more quickly, and I suspect that will happen here as well.
Because say the founder of Weibo just gave millions there to develop a vaccine, but what would be the smallest amount of time? Say if the entire world funded for a vaccine, how long would it actually take to be effective? Or to be safe and effective, as you're saying?
It's a brilliant question, and I don't think any of us know the answer to that.
Yeah.
It's literally months to years.
Okay.
However, the reality is, if this keeps getting worse, there will be pressure to make this happen as quickly as possible.
I mean, what's amazing is the Australian group have already been able to grow this virus, which would be a very important step in doing it. I mean, what has happened in this so far, the timelines have been amazing, because the first case that was identified, they've now pushed that back to the 1st of December. And we're only here now at the end of January. They have the genes of the virus. I mean, that wouldn't have been conceivable 20 years ago or even 10 years ago. They've grown the virus in cell culture. They've got research networks around the world working on it. The timeline, and even The first papers have come out and been published, so the information has been shared. Every day, WHO has a situation update. You go on the website, CDC, WHO, HPSC, everything is happening very quickly. And whereas in the past, it would have taken months to even think that we had to do something about it. So I think it's really been a game changer in terms of the speed with which things happen.
Right. And I know that you have to go now.
Well, I just want to say that so there is precedent, like there are coronavirus vaccines available in animals. So from a technology perspective or sort of a capability perspective, it's very straightforward. But coming back to the point you made about influenza, like every year we generate a flu, but even for the manufacturing capacity for that, it takes about 6 months to get up and running. So to start from just growing the isolate for the first time to having something that's going to work.
And that's why the influenza vaccine isn't 100% effective, because it can change, I suppose, by the time the vaccine is out.
Exactly, it's one of the reasons, yeah, there's a 6-month lag between choosing the viruses that are going to go into the vaccine and then starting the vaccination program. So
perfect.
One of the really cool things about this is there is a new technology, and they're putting money into developing a vaccine from a messenger RNA, which is effectively like the viral RNA, that when you put it in, it could start making proteins. And so that would be something that the manufacturing of a standard vaccine like influenza, if you needed chicken eggs or anything, you wouldn't probably need that for this. So it's a new technology that might increase the likelihood of getting this. And one of the publications said, hopefully within 3 months. I think that's unlikely, but wouldn't it be wonderful?
Yeah, no, that sounds great. Sounds quite undoable, but very much. So I just have, before we go to questions, I just have a final thought maybe from everyone. How would Ireland cope with an outbreak if it did reach here? I know we have a lack of isolation beds. Thanks very much, Cillian. We have a lack of isolation beds, we have other things in place, but like, how would we cope if the virus reached? I suppose, Karina, maybe you can start working in a hospital.
Working in the hospital. Yes, our hospital situation and our need for more isolation beds generally and more beds generally is a real issue. But I'm quite sure that all of the resources would be deployed to ensure that we would cope very well. I think one of the things about this virus is that, and for SARS and for MERS, so there is some experience there, that it's really very simple isolation procedures that are necessary. It really is about that droplet protection and hand washing and, okay, single rooms, but you don't necessarily need the highest levels of technology to contain this. So I think there are a few things that will be very helpful. One, with the Australians growing it, the first thing is also to develop a test for this, because at the moment we're relying on actually detecting the virus, but whether they can do more rapid antibody testing so that you can do that more broadly, that will be very helpful, so that you know who has it, so that you know who to advise in terms of preventing spread. So I think the healthcare system will come up to the mark and that we will cope. But yes, it will highlight the deficits that are there, the need for a proper national isolation unit, which we do not have, that will be up to the standards that will be acceptable anywhere else. And that is a resource issue and a funding issue that needs to be addressed, because there does need to be a state-of-the-art national isolation unit. If we look back over the number of years, I mean, even going back, first there were the bioterrorism scares with anthrax back then. That started thoughts about a national isolation unit. But then since then, we have had SARS, there's been MERS, there's been pandemic flu, and actually we're still lagging far behind in terms of our facilities.
All right, and Nigel, how would you think we cope?
I do think our government need to not be complacent. We need to learn from other countries what they're doing. Flights that are coming in from those regions, we need to be screening people. We need to make sure that those people do go into quarantine. The HSE are doing a report, I think at 2 o'clock, to give us some information about what they're actually doing. But if we have a few cases, I think what Karina says, absolutely, we will cope with that. Would we cope if it was the same situation as China? I don't think Wuhan is coping either, but look what they're doing. They're making 2 huge hospitals. We find it hard to make a children's hospital. And I think we probably would need to think about, where we would put people. There are lots of hospitals, there are lots of buildings that are underused. We would have to reallocate those. We'd have to think about those things. But really the reality is that's so unlikely at this moment, and there shouldn't be a freak out about this situation. We have no cases in Ireland, and we have no cases in the United Kingdom at the minute. And so while, of course, it's important and not be complacent, we need to have a plan, but there's no point in sensationalizing it yet.
So no need for a panic. And David,
I think, most of the burden of care for these patients will fall on primary care, not the hospital setting. As Karina said earlier, it's a small number of people who become very unwell with this, and they're mainly elderly. So most of the burden of care of actually managing the disease will fall on GPs and community health teams, and probably in reality most of the isolation, if it's required, will happen in people's homes or similar settings. It won't be in hospital for the majority of cases, and the complexity will be around managing the really severe end of the spectrum, and whether we have the resources to manage those or not. But it's incredible to think what they've done in a city the size of Wuhan to, the logistics in terms of feeding people, just the day-to-day living requirements of people and how they're managing that when cordoning off a huge city. It's incredible, and I suppose we can learn from that. They're able to do it, and we can learn from it. I don't think we'll be building any hospital within a fortnight like they're doing, but.
Perfect. So we'll just open the floor up to questions before we finish. So we've around 10 minutes. So we have a roving mic there, so just go down there.
Thank you very much. It's been very interesting.